Alrighty. What is up, guys? Welcome to the Triage Method podcast. This week, I'm recording with Mr. Alan Flanagan rather than Paddy. So we're going to be discussing the topic of nutrition as it relates to cardiovascular disease, in particular atherosclerosis and the path there to cardiovascular disease. So for those of you who have been listening to the podcast regularly, you'll be aware that the last number of episodes have been focused on cardiovascular disease and cardiovascular health, both as it relates to exercise and nutrition. And so far we've discussed things like blood pressure. We've discussed basic cardiovascular physiology. So how does everything work when things are working normally? We've also discussed concepts of causality. We've discussed the atherosclerotic process. And now basically what we're going to do is move on and talk about what role does nutrition play in all of this? And importantly, what can you actually do to minimize your risk of cardiovascular disease and ultimately cardiovascular death in the long term? Because none of us want to die. You know, we want to live forever. That's the goal. So I'm here with Mr. Alan Flanagan. Some of you will have heard him on the podcast before. He was last on to discuss the topic of chrononutrition, which is an area that he's researching. So Alan, what's the story? Who are you? Why are you here? And what are your areas of interest? And also, how did you get into this interest in kind of lipids and cardiovascular disease?
Yeah, I think so. I mean, in terms of who I am, I'm currently a PhD researcher at the University of Surrey. And I am quite active, I would say, in the science communication realm through my website, through Sigma Nutrition as well, where people may have found me on either the podcast, myself and Danny are doing more regularly, or even a lot of kind of statements on various issues that we've been putting out over the last couple of months. And although I am, in terms of my actual PhD, focused on chrononutrition, I think my first real love when it comes to nutrition science is cardiovascular disease and lipids. That comes and being at a university that has some really amazing nutrition scientists and lipidologists. And I just got quite interested in it, particularly because, like a lot of people, there were a number of big kind of meta-analyses that came out, the first in 2010, another in 2014, and another in 2015. And they formed this kind of triad of meta-analyses that are repeatedly cited as evidence for there's no association between saturated fat and heart disease. And like a lot of people, I took meta-analyses at that in nutrition relatively at face value. I was kind of inspired by one of my MSc supervisors to really look, when it comes to nutrition and meta-analyses, really go beyond and look at the inclusion criteria, look at the included studies, consider things like the actual levels of intake in each primary study, and all these kind of variables we can dig into down the line. And I got quite fascinated into how you can have an area that really appears on one level to be quite and mired in controversy. So over the last year, that has kind of accelerated, and with Sigma Nutrition, we ended up putting out they were the very first statements we put out, a series of 3 long form statements on diet and cardiovascular disease. One where we focused simply on blood lipids and cardiovascular disease, so the lipid heart hypothesis. Another where we focused on the effect of diet in controlled studies on specific aspects of lipids. And then one on more the diet heart hypothesis, which is the effects of both of those preceding statements on cardiovascular disease events and mortality. And those statements generated quite a lot of engagement and response, in particular from a very prominent member of the kind of lipid skeptic, that's being polite, let's just say community. He eventually ended up having a podcast where Danny moderated somewhat of a kind of debate conversation between myself and this individual, and we had a lot of productive conversations. To be very fair to my interlocutor, he, unlike many people in that community, is very willing to engage, is very willing to stay measured, does not engage in histrionic kind of nonsense. And so it was productive. And yeah, it's kind of grown legs. I'm on the advisory panel for Heart UK, the cholesterol charity here, along with a number of, I'm really, really out of place on that panel. I mean, so like Professor Gary Frost, Gordon Ferns, like, and then there's me. No, there's a few other people as well. But I'm quite interested in, and more so, it's an area for which that interest is seemingly of utility right now, because there is so much, not just like mild controversy within academia, but really loud clouding of the knowledge that we do have by people who simply don't want to accept the evidence as it stands, and will do anything they can to pick a hole, turn it on its head, and cast doubt on what people should do from a dietary perspective for cardiovascular health. And that's becoming quite problematic. So the more that we can engage in this conversation, the more that we can kind of hopefully steer people towards the right steps to take from a dietary perspective to manage, long-term cardiovascular risk.
Yeah, and one of the things you alluded to there was something that I brought up in the last episode of the podcast, where there's basically sometimes this element of false equivalence between the types of arguments that are raised by quote unquote LDL skeptics or cholesterol skeptics or whatever you want to call that group of people, you'd say. And what ends up happening is that you've got this ridiculously large body of evidence of, as you always say, converging lines of evidence, that come to this conclusion related to LDL and cardiovascular disease, etc. And you'll find these little nuanced questions that are kind of like, oh, we're not entirely sure how this plays out, all of the time with this specific profile or something like that. And what ends up happening then is that exception is given kind of like false equivalence to the whole body of evidence. And it's like, oh, this refutes
right.
that, even though it's not actually addressing the core question at play. So without digging into those nuances just yet, one of the things I'd like you to kind of go through is, like, where did this kind of, firstly, I suppose the lipid heart and then the diet heart hypotheses, where did they come from? Like, how did we get here?
So initially, the research into atherosclerosis and the development of atherosclerotic plaque goes back to the early 20th century, specifically a Russian researcher called Nikolai Anishkov, who was based at the SARS military hospital in St. Petersburg. And the seminal paper that he published detailing the development of atherosclerosis from diet was in 1913. It wasn't actually translated. It was in German. It wasn't translated to English till 1981, but it was taken up by the field. And what he had performed were a series of experiments in different animals: rats, rabbits, guinea pigs, also dogs at the time. Dog lovers don't just, it was 1913. And interestingly, for example, rats and dogs, you could feed them heaps of butter and their blood cholesterol levels wouldn't change. They wouldn't develop atherosclerosis. We know that actually that the reason for that is they have very efficient bile conversion, and they recycle cholesterol really quickly and they don't get adverse effects. Rabbits, on the other hand, developed atherosclerosis really quickly and their cholesterol levels shot through the roof. Some of the criticism around the time was, well, rabbits are herbivores and you're feeding them, butter. So you're going to get that response. But essentially, to cut that aspect of the long story short, what Anishkov showed were two things that ultimately stand today. One is that the driver of atherosclerosis, of the development of plaque in the arteries, required high levels of cholesterol, what we now know as LDL cholesterol. At the time, they didn't differentiate. So there was two things. One is that high levels, and that cholesterol itself was sufficient to drive this process, elevated blood levels of cholesterol. That research didn't gained ground, but not as much as one might think. And a lot of it was based on the distinction that, well, look, rabbits aren't humans, which is fair enough. Fast forward to the end of the Second World War, and we have a dramatic shift in human diets as a result of the post-Second World War period. The Second World War gave birth to the kind of industrialization of food production, and newly affluent societies were in a position where people had purchasing power for foods that were previously relatively rare. So depending on someone's socioeconomic status pre-World War II, daily luxury. Foods like meats and eggs tended to be, and even milk, tended to be more expensive. And so while milk was a little bit more consumed, the ability to have fairly daily and ubiquitous consumption of animal fats hadn't really started to occur in diets until the post-Second World War period. The diet and lipid heart hypothesis are related but separate. The lipid heart hypothesis comes from Anishkov's research and was developed further. The lipid heart hypothesis, is that elevated levels of LDL cholesterol are causative of atherosclerosis. Well, we say causative now, but the hypothesis was that elevated levels of LDL cholesterol drive the production and development of plaque in the arteries. The diet heart hypothesis is based on the role of diet in that relationship. So the diet heart hypothesis focuses cholesterol as well, and hypothesized that elevated levels of saturated fat and low levels of polyunsaturated fats were the main driver of high blood cholesterol levels and then contributed to heart disease. And that was supported by a large cohort study in the late 1940s in Framingham in the United States. And it was also supported by a number of other big long-term cohort studies, the most famous of which is known as the 7 countries study. And the 7 countries study was a cohort study based in 7 countries in 18 different regions. So within certain countries, you had different cohorts in different regions of the country where their diet might differ. So in Croatia, for example, you had a cohort that was based in the coastal region of Croatia, eating a kind of more seafood-based unsaturated fat diet, and you had an inland cohort that were eating more animal fat. In Finland, you had 2 cohorts. They had relatively similar diets, only varying in the actual amount of saturated fat. And then you had, for example, a Japanese cohort where they were consuming 5 or 7% of their diet from saturated fat and only about 20% from total fat. So the 7 countries study it gets a really bad rep in the low carb community. As a piece of epidemiology for nutrition, it was excellent because it had huge contrasts in the exposure of interest, which was saturated fat. But the most important thing is tables and observational studies is that through the 1950s, a body of tightly controlled metabolic ward studies where every morsel of food fed to patients was controlled, manipulated the effects of different dietary fats and manipulated the quantity of those fats and manipulated and came up with a very clear picture that emerged through that time frame that the single biggest contributor to raising blood cholesterol levels in humans was animal fat or dietary saturated fat. The greatest reduction in blood cholesterol levels would be seen when vegetable fat, specifically polyunsaturated fats, replaced fat-saturated fat. And that blood cholesterol, and here's the interesting thing about the dietary cholesterol thing. Saturated fat diet, but its effect in isolation was very little. And ultimately, this generated what's known as the Keyes equation, which still stands to this day as a predictive equation for the effects on blood cholesterol of different quantities of saturated to polyunsaturated fat. And that established kind of relationship, what they call the P to S ratio, polyunsaturated to saturated fat ratio, that was established in these metabolic ward studies in the 1950s and is as clear as day in those studies, again, still stands in 2020. In fact, it stands in every line of evidence that we have. So the lipid heart hypothesis really came from those early observations in animals that perhaps it's the cholesterol that gets elevated that then drives atherosclerosis. That started to also be evident in humans through the 1940s, late 1940s and early 1950s, that actually the common denominator in heart disease patients was elevated levels of cholesterol above other factors, although other factors are involved. And as a result of that big kind of nascent understanding of that relationship, the emphasis through that same period on the dietary variables very much focused in on the LDL cholesterol raising effects of saturated fat. And it's important to contextualize that because of the dramatic increase in the consumption of animal fats in the diet, this research was being conducted at a time when in Western industrialized countries, people were 19 to 20% of their total daily energy from saturated fats. The Finnish had the highest level of saturated fat in the world, which was up around 24% of total daily energy. The UK was 19 to 20, the US was 19 to 20, and you had countries that had gone through this transition who were consuming, nearly a fat at the time.
Perfect. So basically what we see is that there is this strong relationship at the kind of population level and the mechanistic and the interventional level of higher saturated fat intakes and atherosclerosis and hence cardiovascular disease. So I suppose the next question related to that would be, have there been examples at that population level where we've seen a population go from very high saturated fat intakes to reductions over time, and how has that influenced cardiovascular disease incidence?
Yeah, it's reduce saturated fat. In the UK, for example, I don't actually have Irish data for this. It's something I should probably look into at some point. But assuming a relative equivalence in terms of the dietary pattern in Ireland and the UK in the 1960s or 70s, 20% of total energy reduced over a 30-year period to around 12 to 13%. And in the UK, there's been a halving of cardiovascular mortality. So in 1962, give or take 1,000 a year. However, in modeling the effects of different interventions that have contributed to that reduction, in the UK, the most significant is the reduction in smoking population-wide. And dietary saturated fat and reductions in population-wide blood cholesterol levels have contributed to that. But that's quite similar to a lot of other European countries where people reduced smoking, they started, there was an increase in vegetable consumption or these various factors. The best example that isolates saturated fat and blood cholesterol levels is the Finnish population. In the early 1970s, and through this period that we're talking about, through the 50s and 60s, the Finns had the highest rate of heart disease mortality in the world. Average life expectancy in males and the average time of death from heart disease was like 50, 55 years of age. was, and in the population, which was heavily agrarian, heavily dairy based, butter was one of the main sources of energy, and dietary saturated fat content contributed up to 24% of total energy. So the Finns enacted in 1972 this really targeted public health intervention to reduce cardiovascular mortality, and they targeted 4 risk factors: blood cholesterol levels and blood pressure, both of which diet and exercise were going to have a role, smoking, and BMI. And if you fast forward to 2007, 8, 9, 35 years later, BMI in the population had increased, smoking levels hadn't changed, blood pressure had come down a bit, but heart disease mortality had been reduced by 80%. And of that reduction in heart disease mortality, the biggest contributing factor was the population-wide reduction in blood cholesterol levels. And that came from a really targeted program of re-education, people to swap butter for, say, rapeseed oil, and to reduce population-wide saturated fat content, which came down from 23-24% to around 12-13%. So, a dramatic reduction population-wide that directly correlated to reductions in blood cholesterol levels. And those reductions in blood cholesterol levels disease mortality, when these other factors that could have had a role, like smoking and BMI, were actually kind of controlled for in a way because they remained unchanged. So that's the most powerful isolated example of the success of this public health intervention, independent of factors like smoking or body weight that can have an influence on the outcome. And the thresholds that we have now currently for, say, 10% of energy, they are evidence-based despite their questioning, and they're based off vascular events. So whether that's stroke, heart disease, any vascular kind of outcomes, they all coalesce as obviously under the umbrella of events. And the 10% threshold is where we see the greatest reduction in events. But this concept of the threshold of intake is so important to the whole discussion, because people talk about nutrition in absolutes, like, oh, it's saturated fat and heart disease. And it's like, yes, but in what context? So a lot of people say, well, there's no, look at this. There's no evidence. Looking at a population where they're already consuming 13 or 14%, and they're comparing it to 10%, you're not going to see a difference between those groups. It's too small, it's too narrow a variability in the exposure of interest. So the real risk for dietary saturated fat was always at kind of thresholds of intake of, say, 16, 17, 18%, particularly 18, 19% and higher. And the reason that this is important is because we have so many people banging on a drum that we should take all the limits off, there's no need to worry. We've already seen percentage increases in the amount of energy from saturated fat in Western countries, and it's a direct result of this type of messaging that people are getting confused about. And I think it's really important that, yeah, sure, if you're consuming an average diet right now in the West and it's 12% of energy from saturated fat, you are not at the risk that you would be if you were consuming 20%. That's accepted. That's not controversial. But it doesn't mean that you should go pouring on the bacon and butter to try and get back to 18 to 20%. Yeah.
Yeah, sorry, it just caught there for a second, but I think I got the gist of what you were saying. So yeah, what I was going to ask with that in mind, with the threshold, I suppose, like, sometimes when we think of kind of foods or nutrients in that kind of good, bad context, people think about totally minimizing them. So in terms of that under 10% threshold, if I was someone who, like myself, I consume, let's say I like dark chocolate every now and then, I like some steak, whatever, and my saturated fat intake, let's say, is 8 or 9% on average, is there likely to be a benefit of me saying, actually no, let's go zero tolerance and cut it all out? Or should people kind of feel comfortable once they're within that threshold of intake?
Yeah, I think people can feel comfortable once they're in that threshold of intake. Even dietary patterns that we consider particularly heart healthy, whether that's the Mediterranean diet or the kind of traditional Japanese diet, both of those diets vary in the total fat content. So the Japanese diet's quite low in overall fat, and the Mediterranean diet's higher in overall fat. But they both have saturated fat. Well, the Japanese diet would be lower, but the Mediterranean. And that comes as a byproduct of eating some of these foods. Cured meats are a big part of the diet in certainly the Iberian Mediterranean diet. The problem with calling the Mediterranean diet is that it's not exactly homogenous. It does differ from country to country. But yes, you will be in a realm of intake where risk is low and minimized, and the idea that people have to get it to 0 or 2% or 3% is actually, from a food-based perspective, rather impossible. If you had 2% of energy coming from saturated fat, it would really indicate that your diet's nutritionally inadequate, because it still comes as a byproduct of all foods. So it's really the total diet that matters, and the balance of these fats and fat subtypes. And if you were eating those foods in the context of a diet where the majority of your fat is coming from oily fish and oils and nuts and seeds and avocado and this kind of thing, then no, these foods in and of themselves are not harmful. And in fact, with dark chocolate, there's an argument that actually the polyphenol content in and of itself, you see good evidence for dark chocolate and blood pressure. And you see, evidence of a different effect of, say, dairy fat. So, there are nuances in the conversation. What we're trying to steer people away from is this idea that you can actually just eat all the animal fat that you like, or you could base your diet from a fat perspective solely or predominantly around animal fats. And both of those are positions that are entirely unsupported by any level of evidence.
Yeah, I think that is interesting, because you do kind of have to think about it in terms of the overall composition of the foods that you're consuming, and whether or not there are additional health promoting or health detracting components of those foods too. Because obviously, if you're thinking about your overall health, like, it's not just LDL, as important as that is. Like, if you were to think about things like comparing something like eating loads and loads and loads of bacon every single day versus eating a mixture of something like, all right, you have a ribeye once a week, and then you have some dark chocolate, and then you have dairy and cheese, etc. There's health promoting elements to those foods, and there's health detracting elements. So I mean, if you're just thinking just saturated fat, then you mightn't be thinking, oh, what about colorectal cancer risk from processed meats, or what about maybe anti-diabetic properties of dairy intake, etc. So yes, the food matrix. And one of the things that you mentioned there, or that I know you've mentioned in the past, is kind of moving towards food-based guidelines. I think from a health perspective, because I suppose that is one of the confusing elements is just thinking about saturated fat and not really realizing that, something like eggs or any food really, you're generally talking about a composition or a mixture of different types of fats. So when we do talk about saturated fats, for people listening, what are the kind of most common sources, and how do they vary in terms of cardiovascular risk, if that's answerable?
I mean, historically, when diets were very high in saturated fat, the 4 main food sources were red meats, and that encompasses beef, lamb, pork, but red meats generally, lard as a cooking fat, butter, and whole milk. Now, if we were to fast forward to now, the main contributors would be milk is still there, as is red meat generally. And essentially kind of ultra processed foods as well. So, baked goods and stuff like that. Although there has been a lot of change in that in the food supply to using kind of polyunsaturated fats. But confectionery, generally speaking, would be a big contributor currently to saturated fat content. But sticking with the foods that have been, I guess, repopularized by various kind of dietary paradigms, whether that's the paleo diet or the carnivore diet, or Dave Asprey's bulletproof coffee and all this kind of stuff that's really venerated animal fats again from kind of meat and butter. Toast in the morning is fine. A ribeye is fine. But basing the diet around those foods, their fatty acid, saturated fatty acid composition is such that, particularly for butter, it's unequivocal from tightly controlled metabolic ward studies that high intake of those foods is going to drive up LDL cholesterol. And high intake of saturated fat from those foods is going to drive up LDL cholesterol. What people have focused on more recently is the nuance to those foods that historically have milk, in the context of dairy seemingly having a different impact. And that may be the case. For milk, however, it's important to kind of qualify that the relationship between milk and cardiovascular disease is much more neutral than it is positive or negative. Whereas it's for cheese, whole milk cheese, and yogurt that we tend to see the benefit, the positive benefit in reducing risk. There are a number of reasons for why cheese and yogurt may differ to milk. And the whole milk fat remains intact. It's encapsulated in this membrane. And that encapsulation makes it behave differently biologically. There's also the process of fermentation itself, which kind of makes the whole food matrix a bit more so that the protein itself is attached kind of to this encapsulated fat. The high calcium content results in the formation of these soaps in the gut, so you don't actually absorb as much of the fat from these dairy sources. You excrete more of it. And cardiovascular health. So like you correctly pointed out, it's not just all LDL. So dairy products have quite a beneficial impact on blood pressure in particular. And that might be a combination of multiple aspects of the dairy food matrix, whether it's the protein content, which protein tends to have a positive impact on blood pressure, calcium, phosphorus, magnesium. So dairy is quite a rich food matrix in beneficial dietary components. Whereas butter, all of those products that we're talking about, all of those components of food that we're talking about, process of fat is churning removes the calcium, and so butter really doesn't have these nutritional qualities that a whole milk cheese or whole milk yogurt has. And the same goes for steak. It will be high in protein, and yes, it will have iron, B12, other beneficial nutrients, but purely from a dietary fat perspective, it's not really giving you anything additive in terms of benefit. So I think that is an important qualifier. The hesitancy that people have in public health, it seems, for allowing whole milk dairy into food-based recommendations is because we are on this precipice right now, this tricky time where people are assuming that they can just go back to eating the steak and the butter. And if everyone just starts throwing back the whole milk on top of that, then their total saturated fat content is going to go up. So public health messaging gets a bit of a... There's a lot you have to factor in when you're messaging for the whole population. So as it stands right now, I tend to stick by the public health recommendations to consume either a skimmed or semi-skimmed milk or low-fat dairy produce generally. And that's simply because being wary of the fact that someone could quite easily significantly increase their total saturated fat content. And, you know, particularly in a country like the UK or like Ireland, where lads in particular are looking for any able to just eat. So we need to be careful with public health messaging and how we convey what's an exception to the rule, as opposed to the exception literally invalidating the rule, which a lot of people, even a recent paper by a lot of respected, you know, people in the field of nutrition science, you know, argued really by hitching its wagon to the kind of foods, and almost posits that, well, this exception invalidates the rule. It's not. It's an exception, and the rule still stands.
Yeah, I think that point related to public health messaging is incredibly important, because that's something that I see getting lost on a lot of people within the fitness industry, and was certainly lost on me in previous years. Because I suppose if you're thinking about your position on whole milk, let's say, but you're thinking about that in terms of the population level, whereas you're not necessarily saying that, let's say I was working with you and you were my nutritionist, and I said, okay, Alan, I'm actually having, you know, most of my fat tends to come from salmon and nuts, or whatever, and I'm trying to get my calories up or get some protein in after a workout. Is it okay if I have some whole milk? You know, that's a different answer to what you'd be giving on the population level.
Yeah, yeah, absolutely. If someone's overall dietary saturated fat content was low, you know, in that range that we're talking about of, say, like, you know, 8%, for example, and they have a steak every now and then, they like their bit of dark chocolate, but in their diet is kind of more unsaturated fat from those sources, and they're talking about, and even there's some research that suggests that than low-fat milk. So if you're talking to an athletic population, an individual client, and you know what their dietary pattern is like, then yeah, you could say drink whole milk. There may be some additional benefits here for NPS and your recovery. But for the whole population level, the messaging is completely different, and we have to account for human behavior, which is not rational. So the messaging has to be careful at a time when in Ireland and reject all science and just start eating bacon and meat and butter again. And so this could easily be a problem from a public health perspective in quite a short time frame, because in our populations with our historic food environment and very agrarian agriculture-based economies, people want to hear that message. You know, if you're a 55-year-old Irish man with, you know, with a bit of central adiposity and a bit of elevated cholesterol, you want to be told that you don't have you know, we do need to be thinking completely differently about individual level recommendations versus recommendations for the whole population.
Yeah, and as I was saying to you kind of before we started recording, like I can relate so much to that desire for public health guidelines just to come out and find that you can eat as much meat as you want, because trust me, like they're literally all my favorite foods. Like I want to be able to eat as much steak and bacon and everything as I can. I want to pour a load of cheese on it, and I want to cook it in butter. Like that's what I want. And I also feel that I can sympathize with people who, like, as I said to you before, again, you kind of have this like primal instinct, like, you know, meat is manly, you know, and you cook it in butter, and that makes you more manly. Like I get that. I appreciate the mindset, but ultimately you have to practice like both critical thinking and critical feeling, as Eric
Mm,
Weinstein would say, is like,
mm,
why do you feel what you feel, and how does that actually align or misalign with what you would actually
right,
critically think your way to based on the available evidence. And ultimately,
right,
for me, like that feeling of feeling more manly is not worth dying of a stroke or being
right.
hemiparetic from my 60s. And I think that's something that is lost on people, maybe until you see a family member succumb to cardiovascular disease or something, because you're certainly not
Yeah,
quite as worried about, I know we're very focused on men here, but it is typically men a lot of the time who are like, I want to eat meat. I don't think there's something that it promotes masculinity if you're just that you're thinking, oh, I'm so masculine because I had a heart attack.
right,
That's when it comes
right,
bites you, really.
right. And we have to factor in, particularly whatever about the UK, but with us and our Celtic genes, we didn't look in on the heart disease risk profile with our genetic pool at all. Minor genetic polymorphisms that lead to elevated cholesterol. That the prevalence of people with high cholesterol in our population is not a joke, and in many respects is far exceeds a lot of other populations. So, we need to be, certainly in an Irish context, quite mindful of our, unfortunate predisposition to elevated cholesterol and heart disease, and be careful with our messaging accordingly.
Yeah, so I suppose with that in mind, the kind of summary there for I suppose a listener, if you're a personal trainer or if you're someone trying to manage your own diet, is realize that when population guidelines are trying to emphasize certain nutrients such as saturated fat, they're not typically thinking about someone who is controlling macronutrients and calories and eating loads of vegetables and fruits and exercising and everything, and whether or not you have an additional stake. It's more so related to the foods that are likely to be consumed by a lot of the population. And if we think about Ireland, the full Irish breakfast is something that's kind of almost part of our culture and everyone wants to
Yeah.
consume. And they're the types of things that we're thinking about. Like I know with my own father, he's had cardiovascular events, and he's someone who, if he comes down the stairs in the morning and he's going to have some food, like his tendency would be put a few sausages on the pan, piece of white bread, and eat that. Like
Mm-hmm.
that's what he's going for. He's not thinking about it. So ultimately, at the population level, it's about that awareness of those basic decisions for people, rather
Right.
than like trying to deliver messaging to the fitness industry itself. And
Right.
yeah.
Yeah, exactly. Yeah, we're not talking about macro tracking bros here, really. I mean, because they're in charge of their diet to a way that just the Gen Pop isn't. So,
Yeah, and another question I have there, it's quite a specific question, and it's just kind of because I could see people wondering about this, and it's if someone is, let's say, if they have multiple different risk factors such as obesity, a lack of physical activity, low dietary fiber, etc., versus someone who's very active, great insulin sensitivity, great blood glucose control, good blood pressure, etc., is there a difference in terms of any sort of response to saturated fat feeding? And I'm not talking like at the population level, but is there any like
mm,
metabolic ward studies or anything on those lines?
yeah. So there. I mean, the stat with obesity, particularly central or visceral adiposity, the fat that accumulates kind of around the liver and subcutaneously around the central region does contribute to a kind of change in the overall profile of lipoproteins and of cholesterol. So what you might typically see in someone with a lot of central obesity is they have very high levels of circulating triglycerides, and there's a knock-on effect remodeling. So basically, LDL divides essentially and into these smaller particles that are more dense. They carry less cholesterol, but there's a lot of them. And then HDL, which generally we want in circulation because it's quote the good cholesterol, although in the cardiovascular sciences community, they're not even considering that anymore. But it still serves a purpose for cholesterol recycling. HDL ends up essentially going back to the liver and getting broken down and removed from circulation. So you have this profile of people that will have high triglycerides, they'll have small dense LDL and a lot of it, and they'll have low HDL. And that's typically a consequence in particular of fatty liver, and a feature of the metabolic syndrome and obesity. And they present a different risk profile to this other kind of, description of someone you described. For that population, there's a lot that needs to be done, but generally, yes, the LDL cholesterol, the small dense LDL cholesterol is going to be an issue, but also in that population now there is a move towards directly trying to target reducing triglycerides as well, whether that's through very high dose EPA. Fat content are still recommended, but there's a double kind of purpose to that recommendation. In people with fatty liver, we've typically just looked at fatty liver through the lens of sugar. Oh, it's sugar, drives triglycerides, fructose increases triglycerides, blah, 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 and you develop fat in the liver. We know from really nice metabolic ward studies and tightly controlled feeding studies that there's actually, so sugar is overbiogenesis, the synthesis of new fat from carbohydrate, overfeeding. But saturated fat directly increases intrahepatic triglycerides, fancy term for fat in the actual cells of your liver. If we flip over to, so just around that individual may have a diet in the typical Western diet that is high in both saturated fat and sugar, and is going to require interventions to modify their diet to increase fiber, reduce both of those, or if one or the other is high. And from a pharma perspective, is going to generally not just require interventions to lower LDL, but now is going to require interventions that will reduce triglycerides as well. So if we flip over to a kind of lean individual who is fit and healthy and otherwise, then the question becomes less about these additional complications and more refined and focused LDL cholesterol. So there's a really nice study by a group in Norway last year that really was the first to look at a low carb, high fat diet in a population of young, lean men who were physically active. And there was on average a 44% increase in LDL cholesterol levels. And what people tend healthy, their blood pressure, their triglycerides are low, so they're not a risk. The LDL doesn't matter. Well, no, they're not as much of a risk as the previous person we described with fatty liver and all these other kind of additional risk factors. But LDL alone is sufficient to initiate and drive the process of atherosclerosis. And in this population, LDL, that elevation in LDL, independent of these other factors, is sufficient to warrant caution. And in this study, it was a proper low carbohydrate, high fat diet in the way that people in the where they had around 65% of their energy from fat, 30% saturated fat. That's very reflective of a kind of, paleo style diet that people would be consuming. And the idea that LDL causation is a qualified causal relationship has been disproven. LDL causation holds true in all circumstances. It's just the level of risk will be modified relative to these other risk that the person with fatty liver and all these other extra complications that we described, but they are still going to be a cardiovascular risk. And I hear this argument from low carbers a lot where they're like, well, before the dietary guidelines, people were eating these natural fats, they call them. It's like all fats are natural, but whatever. So people were eating these, these diets rich in meat and heart disease, and there was, obesity rates were really low in the 1960s. And I'm like, yeah, and people were dropping fucking dead in the street from heart disease. Like, what part of those 50% more heart disease deaths in this period pre-dietary guidelines and obesity? So I think we need to stop romanticizing the 1940s and 50s and 60s from a health perspective as it relates to heart disease, because people weren't obese and they were still dying of atherosclerotic cardiovascular disease at incredibly high rates.
So the answer isn't just eat real food. No, you can't just.
No. And this is what I don't understand about the low carb community. By all means, percent of your diet, go ahead. What I don't understand is why the general principles about fat composition in the diet just can't be applied in that circumstance. Why does this ideology of animal fat and low carb have to go hand in hand? Why can't you still just focus on, nuts and seeds and oily fish and avocado and these kind of unsaturated fat-based foods over saturated? I don't understand. Cares about it's the composition of it, and the fairly irrational thinking that goes into justifying why you can eat all the animal fat you want and it's fine if you're like lean and have low triglycerides.
Yeah, that is the thing I struggle with, because it's like sometimes you kind of just want to like mock low carb people just because they all seem to be like that. But at the same time, like, I don't ever want my perspective on the podcast or otherwise to come across as saying that a diet that is rich in salmon and nuts and seeds and you're eating vegetables and you're having some blueberries and everything that isn't an excellent diet, because like you can like there's certain I can't see any reason why one would be concerned about that being unhealthful, unless you're maybe an athlete and you might want more carbs. But I mean, for health, it seems like a great diet pattern.
Yeah, absolutely. It's just, and I do know people that prefer low carb diets that do that, but just community wide, that's not what's promoted. So low carb now, in terms of the ideology of the diet, is very much married to a number of narratives about our dietary guidelines being corrupt and wrong, saturated has never proven. Looks like neither has the theory of evolution, but we're pretty certain it happened. The idea that fiber is a conspiracy, like it just the levels of ludicrousness that this movement adds to its belief systems as time goes on, is impressive. But it's dangerous when it's promoted not just at the kind of populist like Insta blogger level, but perpetuated by legitimate medical doctors, people with and I also noticed that it seems that the media likes to kind of side in that space as well, just because it has an anti-establishment feel to it. They're questioning the guidelines the government told us and they were wrong. And so it's a pretty simple, narrative based, oh, they were wrong, here's the truth quote. So I can see its attractiveness. I can see why people latch onto it. Everyone wants to feel part of a movement that is possessed of people. But the reality is their arguments are really just baseless.
Yeah, and the shocking thing is that you've actually got like it's not like it's just, and I don't say just to be derogatory, it's not like it's just GPs or surgeons or stuff that have this perspective. It's actual cardiologists that sometimes promote
Right.
this idea that
Yeah.
that we should be, and sometimes they're the loudest voices, unfortunately.
Right. Yeah.
But yeah, so yeah, it is interesting, and I think it's something that it kind of goes back to scientific thinking in general, and how a lot of these kind of conspiracy theories and anti-establishment kind of perspectives, which I can empathize with at times, they often come in a package. You know, I saw in the low carb community, they were the same people who were shouting about coronavirus and saying the government were
Right.
trying to suppress you and track you,
Right.
and you know, all
Yeah.
those sorts of things.
Just to give you a vaccine. Yeah.
Yeah. It kind of comes in a package where, you know, you'll have
Right.
the carnivore crowd who are like, I'm just asking questions about vaccines, you know. And that's kind of the typical line. I'm just asking questions. And it comes in this big package of, we're against, you know, everything that's consensus based, essentially.
Based. Yeah, exactly. Yeah. David Robert Grimes at all.
Sorry, that paused there for a second, but
I was saying, do you know of David Robert Grimes?
Yeah, I have his book there, The Irrational Ape.
Right. Yeah. So I was on the pleasure of being on a panel with him and Hannah Ritchie, who's a environmental. Yeah, she's like really like runs this site called Our World in Data with a few other researchers, and it's really cool. But obviously, David Robert Grimes has really dug into this problem of human thinking and rationality as it relates to vaccines and these other kind of movements. But the point he made on the podcast was that, you know, that there's research that shows that those beliefs there's a constellation of them that tend to always run together. And it seems that the underlying cognitive reason for that is essentially kind of arrogance. It's this idea that you know something that the general population are blind to, or they've been lied, you know, knowledge that the masses don't, and it's an arrogance thing, really, that comes back to, and they tend to congregate together these various beliefs. And the point he made was that it's, you know, it's hard not to have disdain for people who essentially, you know, might know that their position that they're advancing is wrong, or at least just have cognitive dissonance about it, but actively seek to promote it to people in a way that they will engage with, believe, and all agree with that, and particularly as it relates to cholesterol denialism. I've shifted over the last year to thinking that I want to engage with that community, and I want to have dialogue, and I want to have productive conversations. And I've realized that they're not interested in dialogue, and they're not interested in productive conversations. And so it's them all as idiots, which is my preference. I would rather label them all as the belief-driven ideologues that they are. But that, if you were to do that, you put the back up someone that might just be starting to believe they're shit, but is just being drawn to it because they think it's legitimate science. And so the reason that I try and resist just being like, this crowd are a bunch of denialist fucking morons, the reason I try and resist that as much as possible is because that are being sucked in by it, that aren't the movement itself, but are being drawn to the information because they're convinced of these arguments. And they're the people, rather than engage with a cholesterol denialist, the purpose of engaging with their material is not to try and address or convert them. It's for those people listening, basically.
Yeah, and one of the things that I think it kind of came to mind as you were speaking, one of the things I always kind of say to myself as well is, when I'm engaging in when I feel like I'm part of a camp, and even if I'm in the right camp, I think one of the things that people fail to do is that to actually look inward as well, because what can sometimes happen is, because you're on the right side of the scientific consensus, let's say, you basically mock everyone on the opposite side who's operating based on ideology. But then when you ask yourself, how did I come to my understanding? You happen to just be on the right side, basically saying, oh, I believe in science, whereas you've never actually had to go through the process of seeking out information organically. And one of the areas that pops up sometimes is like, people will say things like, I obviously studied physiotherapy, and one of the things people will say is, oh, choose physiotherapy first and trust physiotherapists and that kind of things, like blindly. I think it happens in dietetics sometimes as well, where standing up for the whole profession, and it turns out to be this kind of camp-based ideology again. And it's like, no, I don't want to be part of that either. There are many problems within physiotherapy and dietetics and medicine. And I think if you're not willing to accept that there are problems on those sides, and the same ideologically motivated people fall into both camps, I think that is an important step in dialogue as well.
Yeah, I think so. And for people that are, I guess, more scientifically minded, or have done a medical degree, like, what I always try and say, if they are swayed in that direction, is, if you can truly dig through the current evidence base, if you can read through the 2 European Atherosclerosis Society consensus statements, if you can go on the EAS website and watch Professor Chris Packard's talk about LDL causality, or you watch Brian Ferentz's talks about Mendelian randomization, and you understand Mendelian randomization, and you read his research on genomic studies and heart disease, if you can go through all of that and open yourself to it with an open mind, and come back out the back end I just don't think that that's possible. If you've legitimately approached opening to the available evidence with an open and critical mind, I cannot fathom how a rational, scientifically literate medical doctor or nutritionist or dietitian could come out the back end being like, nah, I don't think LDL's causal. So what I try and implore people to do, if they're, well, I have questions over, this, that, or the other, and they're legitimate questions. Oh, I've heard this guy talk, and it seemed very persuasive. I'm like, fine. Assume that you believe this thing now, but approach doing this other research as if you're trying to prove yourself wrong, and see if your beliefs stand up through that process. And I find it really difficult to believe that anyone could come out that back end still thinking anything otherwise, because the body of evidence is so overwhelming that it really beggars belief as to how someone could look at that and be like, nah, don't believe it. All you're left with is denialism. Literally all you're left with is, I choose not to believe this because it doesn't suit my narrative and my worldview. But as far as biological sciences go, and let's bear in mind, I always make a lot of examples, between nutrition and biomedical sciences and why they're different. But it's biological sciences. Like, biology is complicated, and even if a drug acts through a specific pathway, it also does other stuff and all this kind of. And the reality is, we'll never get to a level of certainty that you would have in mathematics, for example, that degree of precision. Mm-hmm. So we're left with real, truly scientific thinking in a kind of Bradford Hill causality, multiple lines of evidence. And I believe that the body of evidence that supports LDL causality and atherosclerosis is the biological sciences equivalent to the body of evidence that supports that the world is a sphere. There is no other body of evidence that's that robust, coming from every line of evidence, from cell culture to epidemiology, interventions to drug target treatments. It's all there. There's no stone unturned. There remain other factors in the cardiovascular risk picture. Sure, we're starting to realize that triglycerides if they're still elevated when you've lowered someone's LDL, are going to give them a residual risk. And yeah, we should get those triglycerides down. We're starting to realize that residual inflammation will be an issue. And that's a treatment. We're starting to realize that's probably not much point in bothering with HDL. You know, all of these nuances are still coming out. And I think in terms of the available pharmacotherapy, particularly with the advent of PCSK9 inhibitors, we're on the cusp of a revolution in treating heart disease and preventing heart disease and reducing people's risk of dying from heart disease if they are at risk. And that revolution is largely pharmacological.
Yeah.
And I think that any movement that stands in the way at the population level is, you know, a nefarious in its agenda, and needs to be put to bed.
Yeah, and the thing is, I actually like I said, and I think like you're alluding to, I do have a lot of empathy for people who are like, let's say you're a personal trainer or whatever, and you obviously you don't have that much education in terms of like specific biological sciences, and especially not the medical sciences, and you're just kind of trying to figure out what's best for your clients, and you come across a UK-based cardiologist who's saying, here's, you know, what you do with nutrition for heart disease. Like, there's obviously an element of, oh, I should trust that authority. And then, you know, if you're not being walked through all of the evidence, it's very difficult to decipher what is true.
Right.
You know, that's one of the things that I've definitely realized this year studying like pharmacology more, that like this stuff is ridiculously complicated, and like there's layers one through 5, you know, where like, you know, you learn what a drug does, and it's like, oh yeah, that's your kind of your introductory instruction on what this drug does. And then the second level, it's like, oh Jesus, it does all this other stuff. And then the third level, it's like, oh shit, they never mentioned that, you know. And that's me as a first year, and like that's going to continue to evolve and evolve and evolve. And the reality is that it's very difficult to distribute that information to people in an Instagram post. And that's why I do have a lot of empathy for people, regardless of, you know, whether or not I agree with them, because I know in the past that I've been the person who thought that saturated fat doesn't matter, or, you know, I can eat it and it's just not a problem. So for people listening, I never want them to think that we're being like elitist or arrogant because we have the secrets, because I think, you know, it is as much of a problem when people just blindly trust authority as when they distrust authority, you know.
Exactly. You know, it's completely correct. And I think it helps that you were able to articulate this. I mean, you know, I often get the question, for example, like, oh, yeah, I've done a lot of quite detailed breakdowns of kind of going into each of them. And I've had one or two, you know, people comment kind of like, I just don't know how to get to that level of depth with an analyze. And I was just like, well, bear in mind that I have been digging into this like a mole since 2012, 13. Like, I've 8 years of digging into this specific question, while having the guidance and an input of to point my thinking in a certain direction and otherwise. So, you know, this wasn't just because I picked up the paper and had some fucking laser eyes and was able to see, you know, oh, look at these included studies, you know, didn't have the right exposure comparison, you know, like, so it's arriving at a point that comes from a depth of study of a specific topic, and that's not something for that reason that I try and have the patience for the people who are listening, not the person who, you know, the cholesterol denialist I'm engaged with some sort of conversation with, or the paper that's come out that's full of woo crap that I'm trying to like break down for people, as tempting as it is to attack the authors, because it's the same people every time. It's more like I want to be able to demonstrate to someone who's read this paper and gone, wow, this must be it. I want to be able to demonstrate to them why it's not what it says it is, for example. And I don't expect people who have, in a general sense, to be able to do that for themselves. I absolutely don't, in the same way that, like if my car breaks, I'm not popping the hood and being like, oh, yeah, it's like I'm wheeling it down to the mechanic.
Yeah.
Like, so it's I think the problem with nutrition is because it's such a right, I eat 3 times a day, for example. We all eat 3 times a day. Let's just say 3. And you multiply that out, like nutrition, diet, food as a variable that we interact with every day exceeds every single other facet of our life. And so it's that element of legitimate kind of the populism of nutrition that makes it a different field to try and navigate this idea of kind of expertise and not on this on the spectrum thereof. Whereas there is a science, we just assume, we default presume, like, you don't stargaze at night assuming that you're on a par with Neil deGrasse Tyson. Like, but people do this with nutrition. So that false equivalence you mentioned at the start, that's a problem. And so people assume that their favorite Insta influencer who says that they speak for the science, it has the same level of kind of insight into that science as, a cardiovascular researcher who has spent 30 years publishing in the field. Flanagan sent me, this is a while back when we were in the midst of this like ongoing cholesterol conversation that we were having. And I'm thankfully not on Twitter, so he was fighting the good fight on Twitter on our behalf. But, Ivor Cummins basically in this conversation, declared himself an expert equal to Jan Boren and Brian Ferentz and these incredibly intelligent researchers. And it's just like, I'm on a par with them. I've dealt with, quote unquote, their claims. And it's just like, no. That is where we get into an extra layer of problem, I think, when it comes to nutrition and also just the diet heart cholesterol skeptic hypothesis, generally speaking. You have plenty of people who have no affiliation to the field, who've contributed nothing in terms of primary research, who are the definition of, those memes about like, I've done my research, and it's like someone in their basement with like the computer on versus like someone in a lab with like pipetting something into a test tube. And that's a problem. And I think that's intractable. It's the people listening on the fence that we really need to be thinking about. How can we stop people joining this movement versus how can we convince the people in the movement that they're morons? Because that's human behavior. We're never going to convince them of anything. So we just need to let them, hopefully, and this is kind of going to sound bad, but like, I think with the human condition, it's not really the worst thing to say if we contextualize it. I genuinely hope that a lot of them get atherosclerosis, because it will, it'll just be like, well,
there was a bit of a freeze there, but I got the gist of what you were saying. but yeah, like I think ultimately, like for the listener, like ultimately, I think one of the messages that was like that hit me quite hard when I heard it was from Nassim Taleb. But basically, what he said is, you don't want to win an argument, you want to win. And if you're thinking about winning in terms of life, like you're ultimately concerned as an individual, as a user of this information, about mitigating risk of cardiovascular disease. So what I would do is think, all right, I need to put that goal ahead of my feelings, okay? Because ultimately, like a lot of these narratives related to, eating animal foods and stuff like that, like they hit at your feelings at a kind of like a primal level, as I said, of like, yeah, we're against the establishment, we eat meat, this is masculine or whatever. Not that there's no women involved in it at all. Some of the most prolific kind of low carb people in the UK are women. But yeah, it is a kind of a typically male thing. Like, I want to eat lots of meat. But basically, like, what I would say is try to put your end goal of mitigating cardiovascular risk and ahead of the feelings that come in the interim, because I think that's ultimately what you want. Like, none of us want to die of cardiovascular disease.
No. Like, I mean, of the diseases that have a preventable component, like, this is one that is still the main cause of mortality in a lot of our countries, in the Western world, rising in the developing world. So, it's something that needs to be taken seriously at a population level and at an individual level. And what the kind of cholesterol denialists, like low carb, high fat, by doing all those things, you won't have a risk. And that's the thing. They're tiptoeing around the fact that there is no way of saying that following that dietary pattern over the course of a lifetime or as your habitual diet is not going to increase your risk. All they can say is it might not, versus a body of evidence that says if you do these things, risk. And if you're doing those things with your diet, you may still be a cardiovascular risk. Like I said, going back to the genetic component, if you're in a country like Ireland, you may not have a bad diet at all, and you may be doing all of these things and still have high cholesterol. And that's where the place that we're at now with available pharmacotherapy is fantastic. So you'll still be able to reduce risk at that point. But I don't want to develop heart disease. And we have a body of evidence that says that eating plenty of kind of colorful foods and polyphenols and vegetables and fruits and dark chocolate is going to benefit my heart disease risk, is going to reduce the level of cholesterol in my blood and the opportunity for that cholesterol to contribute to plaque in my arteries. Why wouldn't I go with the known versus the unknown, to quote Don Rumsfeld?
So with that in mind, you kind of just alluded to it there, but what for people listening then, right, they're thinking, okay, I'm on board. I want to improve my diet, or maybe they already have their diet in check. A lot of people listening to this will probably be, their personal trainers, they prep their meals and all that sort of stuff already probably. But what does a heart healthy in general, from a blood pressure and from a lipids and just reducing cardiovascular risk, what does a heart healthy diet look like? Or not necessarily a day of eating, obviously, but what are the typical features of diets that seem to be health promoting?
So oily fish crops up everywhere, whether you're in Japan or the Mediterranean. But the nice thing about oily fish, particularly because we're becoming concerned with the environment as well, is the minimum effective dose is really not that much. Is entirely evidence-based. And so that's very achievable. It doesn't have to be salmon, which can be more expensive. I mean, sardines, cans, anchovies, herring, trout, mackerel. If you're in Ireland, like, you've got mackerel everywhere. So there are options, and those recommendations are quite solid and very achievable, I think, in a country like Ireland. Aside from that, then you're talking about having unsaturated oils that are rich in omega-9, which is omega-3s. The two best oils for that kind of composition would be extra virgin olive oil and rapeseed oil, and people used to be concerned about olive oil for cooking on a pan because of the heat. But we know actually that the polyphenol content of olive oil actually protects it at higher heats. So you don't really have to be worried about cooking with extra virgin olive oil, although you could cook with rapeseed oil instead, because there isn't as distinctive a taste. Some people genuinely don't like the taste of cooking with olive oil, which is fine. So they would be two examples of oils. Oils like flaxseed oil are generally best used as kind of dressings or otherwise. Nuts, the research on nuts and cardiovascular disease risk is really robust, and it may not be the content of nuts appears to be one of the major factors contributing to reduce heart disease risk. If you are making substitutions in your diet now from an environmental perspective, there's also an additional benefit, it seems, to soy from the isoflavones as well. And then different types of seeds, whether that's ground flax. There's also a fiber component. So we're getting really into the food matrix, like with flax, for example. If you're adding, say, flax to oats or overnight oats or porridge, you've got the fiber content, you've got the unsaturated fat content, which is polyunsaturated fat primarily, and you've got like flax lignans and all this kind of other stuff. And so for fat composition, really, you're talking about oily fish, oils that are rich in omega-9 or omega-3, and nuts and seeds. And you can also then consider dietary fiber intake as well, which will have an effect on lowering LDL cholesterol. So that's where you're getting more into kind of carbohydrate foods as opposed to just the fat composition of the diet, legumes, beans, oats, particularly the beta glucan content of oats, a type of kind of fiber and effect on reducing LDL cholesterol, and other fiber-rich grains and whole grains. And collectively then, between the high fiber content and the fat composition, that's generally considered the kind of macronutrient profile of a heart healthy diet. The additional factor then that someone would want is flavonoids or polyphenols, which have multiple effects on improving vascular function. So you're talking about dark skinned berries, other fruits, vegetables, dark leafy greens, dark chocolate, and really heart health is having a ribeye once a week going to detract from that? No. Is having some chorizo in an omelet going to detract from that? No. Is having other kind of foods, is having butter on your toast going to detract from that? No. Just don't have 2 tablespoons of it in your coffee. So it's like those foods in and of themselves are not harmful. It's the total diet pattern that you really want to focus on, and that's going to be a diet pattern that's predominantly enriched with unsaturated fats from marine and plant sources, that is high in fiber, and that contains a lot of polyphenols from dark-skinned vegetables and fruits.
Yeah, and I think what's quite nice about all of that is that I'll ask if you agree, but it seems like that type of diet pattern is like almost universally helpful when you look at the other targets of nutrition in terms of colorectal cancer or insulin resistance or other things that people think of as being targets of nutrition. It seems like that's kind of healthful in general, not just cardiovascular perspective.
That's the thing. There's a nice, as complex as science as nutrition is, there's this really nice simplicity that you can bring it back to, where the composition of the diet will have multiple benefits across a range of health outcomes. Particularly what I'm quite interested in with the heart component and the foods within. So the neurological components of a healthy diet that may prevent against dementia are broadly similar to the dietary recommendations for heart disease. And that's something we really need to take seriously, because Alzheimer's prevalence is expected to triple by 2050. We don't have any pharmaceutical interventions for it, unlike cardiovascular disease. So prevention really is important for that. And you're absolutely correct. Like, there is a massive overlap. What's also nice about human diet is that although a lot of the foods that I recommended there would be available on our supermarket shelves, those characteristics that I described, predominantly unsaturated fat content, high fiber content, plenty of polyphenols, can actually be achieved in multiple diet patterns in different parts of the world. So the food sources that contribute to those characteristics can differ quite widely, but the actual characteristics themselves remain pretty constant, whether you're in, Central America, Costa Rica, or Sardinia, or Okinawa, or, these kind of blue zones areas where the food remain fairly similar. Just the food sources that change.
Perfect. So yeah, I think that gives people most of what they need to know in terms of actually taking action here. One thing I did just want to ask in terms of thinking about people who, right, they're listening to this and maybe they're already in the stages of, maybe they've had an event or they've got established cardiovascular risk factors. Is there, well, it's kind of two questions, but firstly, I know that pharmacotherapy can reduce the progression, not just reduce the progression, but actually regress atherosclerotic plaques. So is that something that is achievable through nutrition? Is that something you see?
No.
No. Yeah. So
no. So here's the thing: you can dramatically reduce your general risk of a secondary event when you're in secondary prevention with diet. And we've seen that with the Leon Diet Heart Study, for example, which was a really great study in the kind of mid-90s. And, quite dramatic reduction. The percentage probably reflects the follow-up time, what wasn't as long. But yes, if you've had a heart attack, you've had a cardiovascular event, you can dramatically reduce your risk of a second event. But we're talking about time to second event changing. The that we now know is the target to get to for secondary prevention, that will not just prevent a second event, but as you said, will actually reverse the buildup of plaque in the arteries, reduce it by 50% or more. That level of LDL cholesterol is unachievable through any dietary or lifestyle intervention, because that level of LDL cholesterol for secondary prevention, which is 30 milligrams per deciliter, the last time any LDL cholesterol was when they were in the neonatal phase, was literally about 1 to 2 years of age. And once breastfeeding starts, once milk fat's introduced, then it goes beyond that 30 milligram per deciliter threshold. So that threshold that is needed to get to have a level of LDL at which we see a reversal of plaque buildup is unachievable through diet. It doesn't mean you don't do all the dietary stuff too. You do. You just make sure that you're on a whatever that just puts you on, that gets you to that secondary prevention threshold that the EAS have established.
Yeah, I think that's something that ties in well with, I suppose, the way that you describe the role of nutrition here in terms of being cumulative lifelong exposure as it relates to atherosclerosis, because ultimately your goal should not be to be in your 20s, someone like myself who's thinking, I'll deal with that when I'm older, I'll deal with that in my 30s or my 40s or my 50s, because ultimately the way that atherosclerosis works, the lesions become more and more complex, and the chances of reduction, whether that be through pharmacotherapy or nutrition, basically reduces as the decades go on. So when you're thinking about nutrition, I think the message would be, if you're in your 20s, it's something to consider now before later, pretty much.
Right, 100%. Like the fact that plaque can start to build up from the second decade of life is something that makes me really wish I had this information when I was 17.
Yeah. You wouldn't have acted on it though. You were bulking. You're
that's it. Bro. Yeah, I was all about the gains, bro. Like 2 half-pounders on a Friday night, Yeah.
But
I
Um,
really need to get my cholesterol checked.
but actually, well, just one final question on that, since I said bulking. Like, I think one of the things that people probably forget when they're involved in weight training and the kind of bodybuilding world is you think you're almost immune to poor health
Right.
effects because
Because
you
you lift
track your
for a living.
calories and like
Yeah.
lift 4 times a week for an hour, you
Uh-huh.
know?
Yeah.
So like, is this something you see as being something that, like, you, even if you're trying to gain weight or lose weight, or you're controlling your calories, to confirm these are all things they should still be concerned about?
Because none of those variables that you mentioned do really anything to LDL cholesterol levels.
Mm-hmm.
Like, we know the variables that impact on LDL cholesterol. Lifting weights is not going to, the magnitude of change in LDL cholesterol from exercise and even weight loss is minuscule. So as far as non-pharmacological interventions go, the impact is diet, and the issue is elevated cholesterol. And cholesterol can be elevated, LDL cholesterol can be elevated if you are young, if you are lean, if you exercise. That someone could have high cholesterol in response to diet.
Yeah, I actually found the exercise information quite depressing, to be honest.
Yeah.
Because normally, like, my expectation going into reading exercise research in any area related to health, I'm like, there's going to be huge effects. It's going to be
Yeah.
amazing. And then you look at the LDL stuff and the lipids, and I'm like, oh, damn it.
Yeah,
But
exactly.
obviously, not to downplay it, because ultimately blood pressure and everything else is still related to heart disease.
And like, it just boils down to the mechanism by which we clear what's known as LDL receptor. And it's just simply the fact that exercise, like, for example, with blood glucose, you exercise, you lift weights, you improve your insulin sensitivity, your ability to uptake glucose into a cell doesn't even require insulin if you've done, a certain threshold of like resistance and stimulation to that muscle cell. We don't have the same equivalent from exercise. Exercise doesn't make the LDL receptor more responsive to increase in cholesterol. So your cholesterol levels just don't really change that much. So yeah, you're right. There are myriad benefits to exercise across a range of health outcomes, including as a risk factor that's influenced.
Yeah, we were actually even discussing, one of the previous episodes. There was recent evidence saying that, being well trained in terms of like anaerobic fitness can actually reduce your risk of even just the reperfusion injury of having a heart attack. So even if you have a heart attack, it affects you less just because you are fitter, which
You're
is
fitter.
quite interesting.
Yeah.
So yeah, as we always say in a lot of these podcasts, and as I know your message is, Alan, the overall goal should be a healthy lifestyle pattern as well as a healthy diet pattern. So, things like sleep and stress and drug use and alcohol, all these things also come into the equation. So ultimately you want your healthy diet pattern to be layered on top of that. So with that said, Alan, you've obviously produced a number of really useful resources in terms of Sigma statements and other podcasts. So if people were trying to learn more about this topic in particular, where would you refer them to? Obviously, you've got your own site as well for professionals.
Yeah, I think I've dug into this. It depends on what level. So on my site, I've done a number of video kind of lectures digging into the actual meta-analyses and how they're. I think for a broad overview of the diet heart hypothesis, the lipid heart hypothesis, and the relationship between the two, the 3 statements that we produced for Sigma Nutrition, which are freely available on the website, are where I would send anyone that's kind of interested in making a cup of coffee and sitting down and reading, probably one at a time. Each of them is, kind of in the region of like 7,000 words, give or take. But they're kind of 45-minute reads, and there's a lot to digest. But that's really where I'd start. They were sequential, so there's a and I think, anyone even with no grounding other than the podcast that they've listened to today, would go there and we'll get a really good understanding of where we're at with all of this.
Yeah, and I mean, for people who are coming here from Triage content previously, you'll know that if you are subscribed to our newsletter or if you're in the Facebook group, we did actually share Alan's statements as well as previous podcasts that you've been on, Alan, along with loads of other resources from the EAS and other places. So, I mean, if you are interested in that, you can find those on our website, and I'll just link them in the description. But is there anything else that you'd like to make people aware of, Alan, in terms of your own site or other things that you're working on?
I mean, yeah, so my site is alineanutrition.com, and it's just undergone a nice facelift, and it's very much more for people who are listening who are either, PTs, fitness professionals, or medical or nutrition professionals. It's very science focused. So I always deliberately say that it's not a lay audience necessarily, unless you're scientifically literate from a different discipline and just have an interest in nutrition. And we do a weekly in-depth breakdown of a particular study, and there is also periodic into detail on a specific topic or an overarching topic that we do regularly as well. So I think for people interested in nutrition as a science and understanding the actual science better, we go into a lot of things to do with methodology and stuff like that. So it's more for geeks than lay people for sure. But yeah, it's a good resource.
Savage. So we will finish the podcast there, guys. That's alineanutrition.com.
Yeah.
And I'll link up to all that in the description box. So Alan, thank you for being here. And guys, thanks for listening again. If you did listen to this episode and you thought, hey, there was some terms in there I was unaware of, I didn't hear this atherosclerosis thing before, go back to the previous episode. We discussed all that. We discussed how it's related to heart attacks, etc. And the previous episodes have discussed all the cardiovascular physiology. So make sure to check those out as well. How do I just stop the recording before? Oh yeah.